Welcome to the deep dive. Today we're plunging into a topic that, well, most people navigate at some point. Pregnancy prevention.
Absolutely.
I mean, it's almost universal when you think about it. Women spend, what, around 36 years potentially fertile?
That's right. And the possible age span for pregnancy is huge, maybe 12 up to 53 in some cases.
Wow. And the stats are pretty striking, too. Something like 30 to 50% of pregnancies are unintended.
Yeah, and even 14% of births are classified as unwanted. It's significant.
So our mission today is really to unpack this huge, sometimes overwhelming world of contraception. We'll pull out the key insights from the sources you've shared, look at how different methods work, maybe some surprising benefits, and the crucial health things to consider.
And it's so important to stress this isn't just about not getting pregnant. It's a really big safety issue for women's health, too.
How so?
Well, for example, spacing out pregnancies reduces risks like hemorrhage, spontaneous abortion, even infant growth issues. So the goal, always, is making sure the benefits outweigh the health risks for you, the individual.
Right. That makes sense. So why is this deep dive so important for you listening?
Well, it's fundamentally about empowerment, isn't it?
Yeah.
Giving you the knowledge to make informed decisions for your health, your future.
And what's really interesting is how much the options have grown, especially, say, in the last 20 years.
Oh, really?
Yeah, there's just so much more available now, more personalized choices than ever before.
So, at its core, contraception is basically stopping the egg and sperm meeting, or maybe stopping a fertilized egg implanting.
Pretty much.
But how exactly do they manage that? Let's break down the mechanics.
Okay, so when you boil it down, there are basically three main strategies that contraceptives use.
Right.
First, you can interfere with ovulation itself, stopping the ovary from releasing an egg. No egg, no pregnancy. Simple as that.
Makes sense.
Second, you can stop a fertilized egg from implanting into the wall of the uterus.
Okay.
And third, you can physically prevent sperm from getting anywhere near the egg in the first place. Okay, three clear strategies. Let's maybe start with the hormonal methods. The pill seems like the obvious place to begin.
Good idea.
I saw in the sources it's incredibly common, like among the top 5 medicines used by 18 to 30-year-olds in New Zealand.
That's right.
Yeah.
It's very widely used. But here's a key
Mm.
aha moment from the research.
Yeah.
The pill isn't always taken just to prevent pregnancy.
Mm.
Many people use it for its secondary benefits.
Ah, okay, that is interesting. So not just contraception, what kind of other things are we talking about?
Well, loads, actually. It's really helpful for regulating periods if they're irregular or very heavy.
Yeah.
That's called menorrhagia.
Right.
It's also used to manage conditions like endometriosis, polycystic ovary syndrome, PCOS,
Yeah.
dysfunctional uterine bleeding, too,
Yeah.
and it's often prescribed to help control acne.
Acne. Okay, I wouldn't have immediately thought of that, so it's quite versatile.
Definitely. It's much more than just a contraceptive for many people.
So how do these hormonal methods actually do all that? What are the main types?
Okay, good question. To get it, we need to differentiate. First, you've got the combined oral contraceptive, the COC.
Yeah.
That's got both estrogen, usually ethinyl estradiol here in NZ in various doses, and a progestogen.
Uh-huh.
And there are different types of progestogen. Some are even anti-androgenic, which is why they help with acne, like drospirenone or cypruterone.
Right, the anti-androgen ones for acne. Got it.
Then there's the progestogen-only pill, the POP, or sometimes called the mini pill, just progestogen in that one.
Okay.
And beyond pills, you've got other progestogen-only options. The depot injection, that's a shot every 3 months, an implant that goes in your arm, and the hormonal IUD, which sits inside the uterus.
Right, so quite a few variations there. Let's go back to the combined pill, the COC. How does it actually work? The sources mentioned it sort of tricks the body.
That's a good way to put it. It basically mimics pregnancy. It creates this continuous high level of estrogen and progestogen, and that tricks the body, specifically the brain and ovaries, into thinking, oh, I must already be pregnant. Yeah, and what's fascinating is how it tackles contraception from, like, multiple angles.
Yeah.
It's quite robust.
Okay.
So first, it stops the pituitary gland releasing FSH and LH, those are follicle-stimulating hormone and luteinizing hormone.
Mm-hmm.
That stops the ovarian follicles developing, and crucially, it stops ovulation. No egg released.
Right, number one.
Second, the progestogen part thickens up the mucus in the cervix.
Yeah.
Makes it really difficult for sperm to get through, like a barrier.
Like hostile environment for sperm.
Exactly. And third, both hormones work to thin the lining of the uterus, the endometrium. So even if an egg somehow got fertilized, it would be very difficult for it to implant.
Wow, okay. So it's hitting it from 3 different directions, basically.
4 if you count the FSHLH inhibition as 2 separate effects on follicle development and ovulation. It's really comprehensive.
Gotcha. And how people use the pill has changed too, right? I remember the packs with like 3 weeks of active pills and then a week of sugar pills.
Yeah, the old way for withdrawal bleed, it's
Yeah.
actually less common now, or at least less recommended.
Oh. What's the thinking now?
Well, the modern recommendation and the safer approach is actually continuous use.
Hmm.
Just taking the active pills, no sugar pill break.
Really? Why is that better?
It leads to fewer side effects for many people, and it's actually more effective at preventing pregnancy because you don't have that hormone-free gap where things could potentially slip up. You're consistently covered.
Okay, that makes sense. Consistent hormone levels.
Exactly.
And this touches on personalization too, doesn't it?
Oh.
The sources mention trial and error, like if you get side effects.
Absolutely. This is so important. If you experience things like bloating or nausea, maybe headaches from the estrogen components,
Mm-hmm.
or maybe acne if the progestogen is more androgenic, you don't just have to put up with it.
Right.
You can and should work with your doctor or prescriber. They can try a different formulation. Maybe a lower estrogen dose, like 20 micrograms, is often used for women over 40.
Okay.
Or switch to one of those anti-androgenic progestogens if acne is the issue.
Mm-hmm.
There are options. You don't have to stick with the first one you try.
That's a key message, definitely. Don't just stop. Talk to your prescriber.
Precisely.
So what about the progestogen-only options, the POPs and the others? When are they a better fit?
They're really great alternatives when the combined pill, the COC, isn't suitable. So think about women who have cardiovascular risk factors, or maybe get migraines with aura. Women over 50, smokers over 35, definitely shouldn't be on combined pills usually. Also, women who are breastfeeding or have just had a baby.
Why not for breastfeeding?
The estrogen in combined pills can potentially reduce prolactin levels, which might affect milk supply. So progestogen only is the way to go there.
Got it. And how do these POPs and, say, the hormonal IUD work? Is it the same mechanism as the COC?
Similar but slightly different. They primarily work by thickening that cervical mucus, making it hard for sperm.
Read the barrier thing again.
Yeah. And they also tend to inhibit the LH surge, which helps prevent the egg being released.
Mm-hmm.
But unlike COCs, they don't usually completely shut down follicle development in the ovary in the same way.
Okay. And I think the sources mentioned a challenge with the POPs specifically. Something about timing?
Yes, that's the big one for POPs. Adherence is absolutely critical. You have to take them within a very narrow window each day.
How narrow?
For most standard POPs, it's just a 3-hour window.
Wow, only 3 hours.
Yeah. There are newer ones with desogestrel that give you a bit more leeway, maybe 12 hours, but still, you have to be very consistent. And that's exactly why their typical use effectiveness, meaning how effective they are in the real world with imperfect use, is lower than some other methods. It's easy to miss that window.
That makes sense. Which brings us neatly to the LARCs, right? The long-acting reversible contraceptives, implants, IUDs, the set-and-forget options.
Exactly. These are incredibly effective precisely because they take human error mostly out of the equation once they're inserted.
How effective are we talking?
Very. Roughly only 1 in 100 women might get pregnant over a year using them, sometimes even lower rates over the full duration.
That's impressive.
And they last for years. Hormonal IUDs usually 3 to 5 years, copper IUDs even longer, and the implant up to 5 years depending on the type.
Okay, so very reliable. Now, let's tackle something that causes a lot of confusion. Missed pills.
Yes. The perennial question.
This is where it gets, a bit tricky maybe. And it really depends on which pill you're taking, doesn't it? Standard, continuous.
Absolutely. Knowing your specific regimen is key. Let's start with the progesterone-only pills, the POPs, because the window is so tight.
Right. What's the rule there?
It's pretty clear. If you're less than 3 hours late taking it, or 12 hours for the disogestrel ones, just take the missed pill as soon as you remember and continue as normal. You're covered.
Okay, less than 3 hours, just take it.
But if you're more than 3 hours late, or 12 for disogestrel, you still take the missed pill right away. But then you need to use extra protection, like condoms, or just avoiding sex for the next 2 days.
2 days, okay.
And if you had unprotected sex after missing the pill but before you realized, you might need to consider emergency contraception.
Right. Good to know. Now, what about the combined pills, the COCs? Let's say someone's on a standard regimen with the pill-free week.
Okay, for standard COCs, the main thing to remember is if you miss 2 or more active pills, especially in the first week after the break or the 3rd week before the break,
Yes.
that's when you need what's called the 7-day rule. You take the last missed pill, Continue with your pack, but use extra precautions for the next 7 days.
7 days. And why 7?
Because you need 7 consecutive days of taking active pills to reliably suppress ovulation and get that full contraceptive protection back.
Okay, 7 days of active pills for coverage. That makes sense.
But here's the interesting part we touched on earlier. If you're taking your COC continuously, skipping the sugar pills,
Yeah.
you actually have much more flexibility. Because your hormone levels are consistently high, you could potentially miss, some sources say, up to 8 consecutive pills
Yeah.
before you'd need extra precautions.
Wow, that's a big difference. So continuous use offers more protection against slip-ups.
It really does. Much more forgiving.
So, sort of a general rule then. If someone is ever unsure, what's the safest bet?
Absolutely. If you're ever in doubt about missed pills, whatever type you're on, the safest thing is just to use extra precautions condoms or abstain for 7 days and keep taking your pills.
Okay, 7 days backup if unsure. And what about, like, being sick? Vomiting?
Good point.
Mm.
If you vomit within about 2 hours of taking any pill, assume you haven't absorbed it. Take another pill straight away.
Right.
And severe diarrhea, if it lasts more than 24 hours, can also affect absorption, so you'd follow the same rules as for a missed pill.
Okay, that's really practical advice. Let's shift gears slightly and talk more broadly about the health benefits and risks. We touched on secondary uses like acne and period control.
Yes, those are significant benefits beyond just contraception.
But are there other, maybe bigger health impacts?
Definitely. And this is a really important one. Combined oral contraceptives and also the depot injection, DMPA, and even non-medicated IUDs are associated with a significant reduction in the risk of developing endometrial cancer and ovarian cancer later in life.
Wow, reducing cancer risk, that's huge.
It is. It's a major long-term health benefit that often gets overlooked.
And what about women heading towards menopause, perimenopause?
Yes, contraceptives can be really helpful there too. The estrogen and COCs, or even hormone replacement therapy, which sometimes overlaps, can help manage symptoms like irregular bleeding, hot flushes, night sweats, sort of smooth the transition.
Okay, so quite a few plus points. But we have to talk about the risks, too.
Absolutely. It's always a balance.
Uh-huh.
Let's start with breast cancer. The data suggests there's a small increased relative risk, about 1.24 times the baseline risk, in women who are currently using combined oral contraceptives, particularly if they're under 35. This risk seems to decrease after stopping.
Okay, a small increase while using it. What about cardiovascular risks? Heart attacks, strokes, blood clots, BTE.
Yes, this is probably the most significant area of risk for COCs.
Mm.
They do increase the risk of myocardial infarction, heart attack, ischemic stroke, and particularly venous thromboembolism, VTE, which are blood clots, usually in the legs or lungs.
How much of an increase are we talking for VTE?
The baseline risk for VTE in young women is pretty low, maybe around 3 cases per 10,000 women per year.
Okay.
But with COC use, that risk increases to somewhere between 7 and 10 cases per 10,000 women per year.
So roughly doubling or tripling the risk, although the absolute risk is still relatively low for most young, healthy women.
Exactly. It's an increase, but the overall number remains small for most users. However,
Yes.
this risk is why COCs are contraindicated, meaning they should be used in certain groups. We need to be really clear about this.
Okay, who absolutely should avoid combined pills.
Right. Generally, women over 50, women over 35 who smoking hugely multiplies the cardiovascular risk.
Right, smoking's a big one.
Anyone with existing cardiovascular problems, history of clots, stroke, heart disease,
Yeah.
women who get migraines, especially migraines with aura, because of an increased stroke risk associated with aura.
Migraines with aura, okay.
Also, women who are obese, say a BMI over 30, because obesity itself increases clot risk. We already mentioned postpartum or breastfeeding women shouldn't use estrogen.
Right.
And finally, people taking certain medications that can interfere. Some anti-epileptic drugs, an antibiotic called rifampin, St. John's wort, even some HIV antivirals can make the contraceptive hormones clear from the body too quickly, reducing effectiveness.
Okay, that's a fairly comprehensive list. So, connecting this back, it's not that COCs are inherently bad.
Not at all. They're excellent for many people.
It's just that for some individuals, those risks start to outweigh the benefits. And the good news is, as we discussed, there are lots of other safe and effective options available now.
Precisely. That's the key message. There's usually a suitable option for almost everyone.
Let's talk about some of those other methods then. Barrier methods first. Condoms seem like the obvious one.
Yes, condoms. Unique selling point. They're the only method that protects against both pregnancy and sexually transmitted infections, STIs.
That's crucial. And they're super common. Something like 90% of people have used them.
Extremely common.
Yeah.
And importantly, they're the only temporary method that men have direct control over.
True. But what about reliability? The sources mentioned issues there.
Yeah, while effective when used perfectly, typical use failure rates are higher. They can break or slip, often due to incorrect use, maybe being past their expire date, or damage from storage, like keeping them in a wallet or a hot glove box, can degrade the latex.
Ah, the wallet storage problem.
Mm.
Right. What about diaphragms? Are they still used much?
Less so now. They need to be fitted by a professional. They cover the cervix, but they have a relatively high failure rate, maybe 16% in typical use, and some association with urinary tract infections. So not a go-to method these days.
Okay. And spermicides, the gels or creams.
Spermicides are chemicals designed to kill sperm, but honestly, their effectiveness when used alone is very poor failure rates, around 29%.
Wow, that's high.
Yeah. Plus, they offer zero STI protection, and you have to insert them correctly a certain time before sex and leave them in for a while afterwards. It really raises the question, as the sources noted, is the hassle and low efficacy actually worth it? Probably not for most people.
Fair enough. Okay, let's move on to IUDs, intrauterine devices. These seem increasingly popular.
They really are,
Mm.
especially now they're funded here in NZ, which makes them much more accessible.
And there are two main types, right? Hormonal and copper.
Exactly. You have the hormone-releasing ones, which contain levonorgestrel. Common brands are Marina, lasting about 5 years, and Jades, lasting about 3 years. And then you have the copper-releasing IUDs, which don't use hormones and can last up to 10 years.
10 years. That's incredible. What are the big advantages of IUDs?
Oh, many. Firstly, incredibly effective, as we said. Failure rates are tiny, like 1 or 2 pregnancies per 1,000 users over several years.
Okay.
They're long-term, reversible. There's no user error day-to-day, no interruption to sex, safe during breastfeeding. Plus, the hormonal ones are fantastic for managing heavy or painful periods. Often, periods stop altogether, which many women see as a bonus.
Yeah, I can see that.
Both types also seem to reduce the risk of endometrial cancer.
Yeah.
And because the effect is localized in the uterus, especially copper, or mostly localized hormonal, they bypass most drug interactions.
So lots of benefits. What are the downsides?
Well, the main one is they offer absolutely no protection against STIs.
Right. Still need condoms for that.
Definitely. And interestingly, some studies suggest IUD users might be slightly less likely to use condoms, perhaps feeling protected against pregnancy. So that's a concern for STI rates.
Yeah.
There's also a small risk of pelvic inflammatory disease, PID, usually linked to the insertion process itself, not the device long term. And very, very rarely there's a risk of the IUD perforating or pushing through the uterine wall during insertion.
Okay, small but real risks to be aware of. What about permanent options? Sterilization.
Yes, for people who are certain they don't want more children. For women, it's usually tubal ligation, getting your tubes tied. This involves cutting, blocking, or sealing the fallopian tubes so eggs can't travel down them. Often done during a C-section if a woman knows it's her last baby. Generally considered permanent.
And for men, vasectomy.
Right, vasectomy. That involves cutting or blocking the vasectomy deferens, the tubes that carry sperm from the testes.
Which is generally considered the safer, easier, and less expensive procedure.
Yes, male sterilization typically has fewer complications than female sterilization. And while it should be considered permanent, vasectomies are sometimes successfully reversed, though reversal isn't guaranteed.
And effectiveness for both.
Extremely high. Failure rates are very low, maybe 0.1 to 0.5%. Very effective permanent methods.
Okay. Let's quickly touch on some less reliable methods people might hear about. Breastfeeding.
The lactational amenorrhea method, or LAM. It can work under very specific conditions, exclusive breastfeeding, baby under 6 months, no periods returned, but overall, it's unreliable. Ovulation can happen before your first period comes back.
Right. Unpredictable. Withdrawal. Pulling out.
Also unreliable.
Yeah.
Preoculate fluid can contain sperm, and perfect timing is, well, notoriously difficult under the circumstances. High failure rate.
Douching after sex.
Completely ineffective. Sperm are incredibly fast. They can reach the uterus within a minute or two. Douching won't stop them and might even push them further up or cause irritation.
Okay, myth busted. What about fertility awareness methods, tracking cycles?
These involve tracking signs of fertility temperature, cervical mucus, and avoiding sex during the fertile window. When done perfectly by highly motivated, well-trained users, they can be moderately effective. But typical use failure rates are quite high because cycles can vary, ovulation can be spontaneous, and it requires meticulous tracking and often periods of abstinence.
So it requires a lot of effort and still not foolproof.
Ex-
Okay, let's look towards the future then. Male contraception. The sources highlighted a pretty big gap here.
A huge gap. Apart from condoms, which are barrier methods, and vasectomy, which is permanent, there are basically zero modern, reversible contraceptive methods available for men.
Zero. So why? What's the holdup? The research pointed to a few reasons.
Yeah, it's complex. One factor mentioned was surveys showing, perhaps surprisingly, that over half the women asked weren't sure they'd trust their male partner to take a contraceptive consistently.
Interesting sociological factor.
Another is simply the success and availability of many effective female methods. Maybe it reduced the perceived urgency or market demand.
Okay.
Then there's the regulatory environment. Safety and efficacy standards for new drugs are way stricter now than when the female pill was developed decades ago. Some experts suggest the original female pill, with its known side effects and risks like VTE, might not even pass today's rigorous trials.
Wow, that's a thought. Higher bar to clear now.
Definitely. And finally, there's a fundamental biological challenge. It's arguably much harder biologically to safely stop the production of millions of sperm every day or temporarily inactivate them compared to stopping the release of just one egg per month.
Right, the sheer numbers involved. So what trials have been done? What are they working on?
Well, they've tried a few approaches. There was a pill trial,
Yeah.
but it caused unacceptable rates of side effects like decreased libido and erectile dysfunction in too many participants.
Not ideal for a contraceptive.
Hardly. Then there was an injectable hormone trial. That showed promise for effectiveness, but
Oh.
it led to increased rates of depression, mood disorders, even some suicidal thoughts, which unfortunately caused the trial to be stopped early due to safety concerns.
Oh, dear. That's serious.
Very. The most promising candidate right now seems to be a hormonal body gel that men rub onto their back and shoulders daily.
A gel. How does that work?
It delivers hormones through the skin. It seems to be effective and, crucially, hasn't shown the same severe mood side effects as the injection in earlier phase trials. Is moving into larger scale testing now.
Okay, so maybe some hope there. What's the underlying challenge with these hormonal methods for men?
It often comes down to testosterone. Many approaches try to suppress the pituitary hormones that stimulate sperm production, similar to how the female pill works. But to counteract the resulting low testosterone and its side effects like low sex drive, mood changes, loss of muscle mass, you then have to give back testosterone.
Ah, so you're trying to shut down one system, but then artificially prop up the things it controls.
Exactly. You're messing with a hormone, testosterone, that's crucial for many functions beyond just sperm production, including libido and mood. It's a very tricky balancing act to get right without causing unacceptable side effects.
Yeah, sounds incredibly complex. Okay, well, we have covered a huge amount of ground today, from the basic mechanics to all the different options, pills, LARCs, barriers, permanent methods, and those really important benefits and risks.
It's certainly a lot to take in, but hopefully this deep dive has helped clarify things. Because as we always say, knowledge is power, especially when it comes to your own health. But it's most valuable when it's properly understood and you can think critically about how it applies to you. There's always more nuance, always more to learn.
Absolutely. So the final thought for you listening, what does all this mean for you? How can you use this understanding, this deep dive, to advocate for your own health choices? Or even thinking bigger, how does this inform our view on the need for accessible, suitable, personalized contraceptive options for everyone, everywhere in the world? Something to mull over.